So here are some learning objectives. I put these together in a hotel room in Vegas when they were due in about an hour. Actually, I looked at them recently, and it's like, okay, they're pretty close to what I'm going to talk about, but they're there. So I've now done in case this was for CME, which I can't remember if it is or not, it's done. And we'll see how closely I come to doing those. I have a couple disclaimers. One, the views are my own, they don't necessarily reflect those of AHRQ or HHS. I do hope that they don't get me fired, but you never know. I wish I had financial relationships to disclose. I remember being able to disclose financial relationships. It was great, but I don't anymore. And then lastly, I am a product of the Beltway. I was born inside the Beltway. I'm a native Washingtonian from this Washington, D.C. I speak in acronyms at home with my wife, who works at FDA, by so forgive me, bring on the jargon jar, which I thought, okay, is that J squared, Jar Jar? I thought for the Star Wars fans I would use Jar Jar, but anyway. Here is a little bit about AHRQ. How many of you know AHRQ's mission by heart? If you closed your eyes, you could repeat it. Okay, so I won't linger on it, except to say we try to create evidence around safety, quality, accessibility, equitability, affordability, and we work with you and other partners in HHS to try to make sure that evidence is known and used. We also have some areas of focus, some products that we create around research and evidence to teach and train health professionals using materials created based on evidence to some degree, and then measures and data used to track and improve performance. Actually, and you can go on AHRQ's website and listen to, or maybe I need to hop down a little bit. Better? Sharon Arnold or our good friend David Myers. Many of you know David. David's a huge supporter of PBRNs. Actually, he was the PBRN director for many years. I know. Thank you. Applause for David. I couldn't agree more. Thank you for David. His opportunity his son got an opportunity to play music in England. So he is in London right now, or very soon, I think, with his family. So I'm very jealous. And Jeff Brady, of course. So videos galore. We are into social media at AHRQ now. So one quick pause here, because you came to hear about the state of primary care research at AHRQ. And usually I would spend the next 45 minutes sort of telling you what I think it is. But you know what? I'm going to cut to the chase. That way, if you have a plane to catch, you can leave. You don't have to stick around for the rest of it. So let me see if I can do this right. My fellow Americans and Canadians, I am confident that the state of primary care research at AHRQ is strong. Okay, thank you very much. Try the veal. Here's what I'm hoping to do today, is to have a discussion. These are the questions I'm hoping that will guide our discussion. I'm going to try to convince you that what I just said is true, despite maybe what you've heard or what you felt. And I'm going to do it by talking about three areas. Certainly what's our past been, where we are in the present, and where we think we might be going in the future with feedback from you. So with that, let's talk a little bit about the past. And we're going to start with a quiz. For those of you who may know history or may not, which of the following was the earliest predecessor agency for AHRQ? Was it the National Center for Health Services Research and Development? Any takers? Was it the Bureau of Health Services Research? Was it the National Center for Health Services Research? Or the National Center for Health Services Research plus Healthcare Technology Assessment? Was it the Agency for Healthcare Policy and Research? Okay, I see takers for that. Or was it the National Institute for Research on Safety and Quality? What was that? I heard AHRQ as being sort of the main one. Well, the correct answer is actually A. All of these were predecessor agencies for AHRQ. In 1968, the National Center for Health Services Research and Development was created almost 50 years ago. And then you can follow the line of succession through all these agencies over many years till you come to 1999 when AHRQ was authorized. And that's when we actually finally became AHRQ in 1999. So sort of a fascinating history, but AHRQ, in one way or another, has been around for almost 50 years. And there's some interesting things. Back in 1969, there was an article in Medical Care that was published. And he talked a little bit about the development of this new center to do health services research. And the quotes that I've pulled out on the right are from Wilbur Cohn, who was Secretary of Health, Education, and Welfare at the time, when the National Center was open. And so I pulled these out because they are just like, they could have been written yesterday. Okay, health services in the United States are expensive and complex. Has that changed in 50 years? No. The result is that providers of health services face demands that exceed the capacity of traditional ideas and methods and institutions. Here we are. This new center will provide a central focus for this kind of new research, act as a catalyst for new ideas and methods. It will work with universities, industry, hospitals, practitioners, and research institutions to seek new ways to improve the delivery of healthcare. So are we successful 50 years later? Have we done what was set out to do? I don't know. I'll leave it to you to decide. And there was a lot of exciting work, but I found it really sort of came together, crystallized, in 1989, when AHRQ was introduced, when AHRQ was authorized. And in the 1990s, and for those of you who've been around for a little while, and I was in DC in the 1990s, there was a lot of excitement. I have these 3 publications on my bookshelf from 1990, 1991, and 1992 for 3 meetings that were sponsored or co-sponsored by AHRQ around primary care research. And they set out to define a primary care research agenda. And you read these things, it's like a giddiness. People were so giddy and excited about the future of primary care and research. I got excited reading them. It's just great stuff. And really, in the 1990s, we were headed towards healthcare reform. The first time we went around, well, not the first time, one of the times before. We've been through it many times, but the Clinton healthcare reform era. This was all leading up to that. Exciting times. And here are some of the things that I pulled out of some of these documents from the 1990s. Jennifer Mayfield, who was at AHRQ at the time, said, it must be remembered that primary care is a very young field. Less than 20 years old, she said, in 1990. And yeah, okay, I guess AAFP founded 1968, right? I mean, so it wasn't that old. And there were few established research programs or experienced mentors. Sort of fascinating observation. Harvey Estes, who I have a personal fondness for as a PA, we think of him as the architect of the physician assistant profession. He reflected on the role of primary care and primary care research at this new agency, AHRQ. Many discussants highlighted the commonalities and differences between family medicine, pediatric, and internal medicine research. Does that sound familiar to anyone? Fitzmullen talked about what the federal investment was in primary care at the time, and he was able to identify that $15 million was spent by NIH on primary care research in 1989. Does that seem like a lot or a little to you? I'm not quite sure. The 2 Larrys, Green and Lutz, describe PBRNs in Aspen. LJ has been reflecting fondly on Aspen over the last few days. And I didn't realize you were that old, LJ. This is going way back. You look so young, 39 and counting. And then the other topics on the agenda: prevention, changing provider behavior, disadvantaged populations, community-oriented primary care. Where has community-oriented primary care gone? I guess it's probably just changed the name, because I hear a lot of interest in sort of the same topic. Substance abuse, rural health, and AIDS. Sound familiar to you? They sounded familiar to me. And then we got, AHRQ got embroiled in healthcare reform. And there was another fascinating article in Health Affairs that highlighted what went on during the mid-90s and late 90s to AHRQ. And one of the things that happened is we became very involved with the Clinton healthcare reform plan. AHRQ was able to generate some modeling numbers around how many improvements in health based on changes to healthcare reform. And you know what? We pissed off HCFA in the process. HCFA was the predecessor to CMS. They didn't like AHRQ stepping on their toes. We now had aligned ourselves very clearly with a democratic healthcare reform that Republicans did not like. And then when Republicans swept into office in 1994, not only did we have few friends, because AHRQ at that time was mainly advocated for by health services researchers. So they were sort of a self-interest group. AHRQ supported them. They were the only advocacy group for AHRQ at the time. And then we had a lot of enemies, not only within Congress, who thought AHRQ was redundant with NIH. Why would you need another research agency? We annoyed back pain, or orthopedic surgeons with back pain guidelines. We annoyed ophthalmologists with ophthalmology guidelines. We had a lot of enemies and very few friends. And it was only through the charismatic leadership of John Eisenberg and important relationships that he had built, that were able to sort of migrate from AHRQ into the modern day AHRQ. And it was John Eisenberg, and I sort of have to genuflect and bow when we say his name, John of AHRQ. We really owe him a lot for what he did to save the agency. But many of the stories are familiar today, and I love some of these quotes from this Health Affairs article. The Agency for Healthcare Policy and Research has had a turbulent history. Substitute AHRQ in there. Let's see, how many times have we been zeroed out of the Congress budget in the last few years? We're on our 4th director in 5 years. We just had a big move, there's plans to integrate us. I mean, there's a lot going on with AHRQ as well. And I love the second one about health services research is about as difficult to sell as dead fish wrapped in newspaper. But actually it's the third one that I thought was most compelling for us in this room. And we think about this a lot now, and we need your help thinking about it, that funding is more forthcoming for a research agency if plausible arguments are made that it can do something to address real-world problems. This is, I think, still particularly relevant for us today, and we need your help with that kind of question. And actually, this is just sort of, I can't help but throw in a little trivia. This is the budget trajectory between 1980 and 2002 for AHRQ and its predecessor agencies. By 2002, despite the near-death experience of the late 90s, we had a budget of almost $320 million. And later on, I'll show you the modern numbers and where they pick off. So interesting, despite some of the turbulence, the trajectory sort of funding was still fascinating. And then there's one last thing that I want to talk about from the past that is a legacy for today, and that was in AHRQ's authorizing legislation in 1999, we were designated to have a Center for Primary Care Research. And as you know, that center was pretty much in the Center for Primary Care Prevention and Clinical Partnerships since about that time at AHRQ. We dissolved that center or merged it with other centers at AHRQ, took the primary care part out, and that is what led to our modern day National Center for Excellence in Primary Care Research that's led by Ted Ganietz, who you heard from certainly last year and has been at this meeting as well. So that's where the sort of the center part comes from. Okay, let's move into the current state. And past is prologue is one way to think about it. And this actually comes from a quote from Shakespeare, actually, Tempest. And the way that Shakespeare meant it is the past means nothing. Whatever you do today and moving forward is all that matters. But actually, I've often interpreted this the other way, that those who do not learn lessons from yesterday are doomed to repeat them in the future, or whatever that quote is about understanding our past to help us understand our future. You pick whichever interpretation you like, that the past is dead to you or that the past matters moving forward. And as we began the modern day work at AHRQ around primary care research, we began with a simple credo. And this is the credo. It's on all of our web pages. We included this slide in all of our presentations about primary care. And it was this commitment that we believe revitalizing the nation's primary care system is foundational to achieving our mission of improving quality, safety, accessibility, equity, and affordability of healthcare for all Americans. That's all we had to start with. This credo that primary care is important. And what are we going to do to fix it? The second thing we had was a conceptual model. We used the expanded care model, Dr. Barr's work that expanded on Wagner's work, and we picked off these things one at a time to try to figure out what can we do to fix all of these things to build a system that works for the future. And that led to sort of thinking about the PCMH. As many of you know, the patient-centered medical home, the joint principles were written in 2007 by 4 physician organizations. AHRQ took them and made them AHRQ's own, added the AHRQness to them, made them something that we could work on, act upon, and we picked these as principles around the patient-centered medical home as AHRQ thought about it, to provide patient-centered, comprehensive, coordinated, accessible care that continuously improved through a systems approach to quality and safety, with a recognition that health IT, workforce, and financing were important as well. And then we undertook many of these projects, these research areas around understanding the PCMH, around practice facilitation, really thinking about you guys, how do we invest in you, integrating primary care and behavioral health, thinking about care management, self-management support, health IT, and team training. Some of this we did by grant, some we did by contract. We have sort of 2 mechanisms available to us to move AHRQ's work forward. And we had a mix of both for these. Some of these you may have been involved in, and perhaps some not. We also had a variety of targeted research programs, and most of these were grants. Actually, some of these were my first introduction when I came to AHRQ about 5 years ago. The Transforming Primary Care grants, we learned a ton from those. We also had 4 impact cooperative agreements at Oklahoma, it was New Mexico, North Carolina, and Pennsylvania. They actually were the predecessors in many ways, the learning laboratories for us, for our Evidence Now program. In some ways, we learned so much from them. We also looked at what it would cost. We've done some work around multiple chronic conditions, around models of primary care workforce, opioid abuse most recently, to really target some of those research areas. And Evidence Now, I'm not going to linger on. You heard a great talk from Deb earlier. It's percolated through many different things here. Great slides, by the way, Deb. I mean, I just love who creates those for you. They're just great. I won't linger on this one, blah, blah, blah. Yes. The only thing I'll add to this, and you had a better slide on this one, sort of Evidence Now by the numbers, is the very last one. So we recently had to send some very bad notes to people about funding cuts or potential cuts to funding in that program. And it was very painful, both for the grantees as well as for us at AHRQ. And I did a little bit of work to try to understand how painful it was, and found that there's about 500 people who are supported by that grant or work on that grant. That is not a small number of people who are at the universities, who are at the contractors, who are at AHRQ, who work on these things. Actually, that funding can have a significant impact on people's lives, which was a way I hadn't quite thought about it before, but important to think about. And then lastly, a map. I changed the coloring so it would come out this time. We got to work on that one because I've had it come out faded as well, but you know who you are. And then lastly, I want to talk about this one because these are the 5 services we sort of hoped or suggested that our cooperatives provide. And these services, the evidence for the effectiveness of these services came from you. We learned from what you were doing at PBRNs to understand the value of data feedback and benchmarking, to understand what kind of electronic health record support is needed, to understand the value of shared learning collaboratives, and academic detailing, or what we call expert consultation, and then a practice facilitation, of course. And so these are important things that we think about that we couldn't have thought about without your help. And then I won't talk a lot about the National Center. You heard from Ted last year about our vision for it, but it is really going to be the main way we want to communicate with you about primary care research. And then there's the SEN. Arlene talked about this yesterday, a little bit what's in the SEN. Feel free to dig it up. I am the contact person on that. If you want to talk about it, happy to talk with you about it. There's a bunch of stuff on here, and I know from the field's perspective, an SEN sort of doesn't really mean anything. It means a little bit, but there's no money attached to it, so why should you care? But I can help talk you through that about why you should care, because there's still this big pot of investigator or initiated research money, and I would love all of it to be dedicated to primary care research. And so we need good applications, and by following this a little bit, and some of your other ideas as well, we can help sort of make that happen. Okay, quiz time again, because we sometimes reflect the heydays of funding are over, aren't they? You know that, man, there's just no money anymore for doing primary care research. So I took a little look to see when did we spend a lot of money on primary care research and when did we not? So if you had to think about this, given a few choices, what year would you say we spent the most money, gave away the most grant awards, and provided the largest annual funding for primary care? Anybody say 2008? How about 2010? One over in the corner, very good. How about 2012? Okay, so the good old days weren't that far back. How about 2015 or 2016? Okay, there's a few more there. Okay, so you think better more recently. That's good. So the heydays are not over, perhaps. Well, it was actually 2010. Good for you. A prize over there. It was the era of era, as you know. We had lots of money to give away and to give away quickly. And that year we gave away 144 primary care related grants of about $87 billion. And you can see in 2008 and 2012, pretty consistent, around $26 million in primary care research. And 15 and 16, for those of you who thought those were big years, that was our Evidence Now money we started giving away in 2015 through the PCOR Trust Fund. So, but do you really want to know? I did a some work on our grants database to try to understand what some of these patterns were, thinking you might be curious to know. And I looked for grants that had primary care in them, primary care physician, or primary care setting. And granted, that's a pretty big, it's not that specific of a search, but at least it gives me a handle. It's a little back of the envelope calculations. And what I saw that between 2007 and 2017, there were 3,145 applications to AHRQ that had this kind of primary care focus to it. Of those 3,000 that were submitted, over close to 1,200 got awards. The applications represented 1,653 different principal investigators. The awarded ones represent 461 principal investigators. All the money's not going to the same people. That's actually sort of gratifying. That represented 178 organizations that got awards, which I think is pretty cool, and over $415 million in primary care research over the last 10 years. Feels like a lot of money to me. I mean, now, when you put it next to NIH's budget, it's a little rounding error, of course, but at least it's something. And here's how some of those years played out, if you're interested. And I'm just fascinated by the cycle, and I haven't spent a lot of time analyzing this, partly because I'm not sure how much I believe some of the data, which we know is a problem in quality improvement. You just don't believe the data. But there's sort of this fascinating pattern, and throughout 2010, because it was sort of a funny year, but if you look at the next 3 years, we have lots of applications. You know, people get disgruntled because we're not getting approved. We're not going to throw any in. And then all of a sudden, look what happens to the award rate. Like, it looks like it's great all of a sudden. And then we get a lot more. And of course, the award rate goes down, and then it goes down. So this 6 years where we have these 2-3-year interesting cycles. As for 2017, I'm not sure what's going on there. That seems like a high amount to me for 6 months into the year. And I don't know if people are particularly optimistic. If the SENs are driving research applications, not sure. The award amount is so low because we still have a couple of cycles to go yet in this year. But just sort of a fascinating pattern, I thought, around primary care research. And if you look at the money side of it, if you toss out 2010, it's sort of been pretty consistent, just sort of hovering around 30 million over that time till you get to 2015, 2016, where we had that big influx of PCOR money for Evidence Now awards. But sort of, it was fascinating. I wasn't aware, and so it was interesting to do the looking. What I've done here is now taken, you remember there was that graph from Health Affairs that said in 2002, AHRQ got $320 million in its budget. This is the budget line more or less since 2002, total appropriations for AHRQ. And you can see mostly we've been on the upswing. We've plateaued a few times. Recently, we've sort of been leveled off mostly because we've been under the continuing resolution. And it looks like in the budget request for 2018, the president's budget, we're going to dip down a bit. So we may be facing some cuts, but we'll see what happens with that budget looking forward. And interesting to see that we've had the increase in total appropriations, but the sort of level funding for primary care research, though. So what that means, except for the bump up more recently. So we'll have to think about how those things all interact. But a reasonably good percentage of AHRQ's total budget going to primary care stuff. And then we had a discussion, I think, on Wednesday, sort of at the fellows luncheon, about what kinds of mechanisms are available to do primary care research. And these represent applications, not awards. But the big one, of course, is the R18. That's one of AHRQ's favorite mechanisms. R01's also. Good number of R21s, though, which I think is what people were looking for. R03s, a reasonable number as well. Again, this is over 10 years, and just applications, not awards. But I also think it's sort of cool that we got 148 applications for meetings. That's the R13 one, or conferences. We think that the age of conferences is dead, or federal money going to conferences in some way. But it actually looks like it still has some life left to it. And then I also looked at PBRNs to see if I could pin down how much money has gone to practice-based research, or PBRNs. And I found, and you'll have to see if this passes the sniff test with you, about 83 million over the last 10 years to PBRN funding. Sort of interesting numbers to me. I hadn't actually got a handle on what some of these are, so I don't know if that makes sense to you or not. So you've now heard a little about the past. You've heard about where we are in the present. and now we're going to talk about the future. And I'm uncertain about whose quote this is, and it seems the internet is as well, but more people attribute it to Niels Bohr than Yogi Berra, although I'd prefer it be Yogi Berra. He is just a much better philosopher, I think. Einstein or Twain works as well. So pick the person who you think does this. And I'm not going to talk a lot about AHRQ's priorities, but I am going to tell you about the puzzle pieces here, because I actually don't know what the future holds. But there are 4 pieces to this puzzle, and the first one in the lower left I'll talk about first because Arlene, I think, alluded to it yesterday, and that is Andy Beinman, when he came in as director, had a lot of interest in shifting AHRQ to think about learning health systems. I think there's tremendous opportunities there. And by all indications, we will continue doing learning health system work. I think there are opportunities, tremendous opportunities for PBRNs in terms of learning health systems. Okay, so that's one. We also have a new secretary, Secretary Price, and he came to visit us and talked a little about what his priorities were. And his priorities are really around substance abuse and mental health. He is very interested in childhood obesity. He's interested in person-centered care, and clearly he has an interest in decreasing the administrative burden on physicians. These are all things that I think are AHRQable, that AHRQ can put its unique stamp on, and that you can help with that. So I think there's stuff we can work on here. As far as what's in our budget requests for the future, these are the few of the things that AHRQ has talked about, and certainly patient safety has been one of our primary ones. It is the thing that Congress understands about what AHRQ does. If you think about AHRQ, talk about to Congress, they get that AHRQ does patient safety. Not always some of the other things, but also think about technology and how we can advance care through use of technology. And ECHO in particular, I think, was one thing that showed up as being something, or ECHO Plus, something people were interested in. Training physicians and nurses and others in doing quality improvement is shown up in our budget request. And then data, typically through HCUP and MEPS, things like that is also in there. And then, a bunch of us sit around. We have nothing to do on most days, and we sit around the office sort of musing on what should we do next. Just toss around ideas. No, actually, it feels like we're very busy. I went to AHRQ personally because I just want to be a bureaucrat, 9 to 5. Check in, check out. I have never worked harder in any place I've been in my whole career, and I don't know of anybody who works hard. I mean, everybody works really hard. It's amazing. So I had a lot of misconceptions about what it might be like, but it's just been great. But anyway, here are a few of our musings. We certainly talk about advancing telehealth. We talk about electronic care planning. We've done some work around patient-centered care and team-based care, but really relationship-centered care, I think seems to be at the crux of many things to think about that a little bit more. We've also talked about narrative medicine. There's been some interesting articles floating around recently about putting joy in practice by engaging more with patients. I've seen stories by physicians who had to go into a hospital or get care about how objectified they felt and depersonalized they felt the care was. And there's some findings that by having people engage more in sort of narrative medicine, writing down their feelings from both the patient side and the provider side can really improve care from many levels. So we're sort of dabbling with how would we do that? How would we create something that would help train people to do that better? Does it actually make a difference? And then we have our sort of body of work around multiple chronic conditions, and we're sort of, where do we go next with that? Certainly continues to be a huge issue, especially as we think about how much money we spend on care. And then there's Evidence Now 2.0. What should be the next big thing? Actually, Deb highlighted, I think, really nicely yesterday about a dozen different spin-off projects. I know in the visits I've had with Don and their cooperative in the Southwest, it's like all these studies within studies that you could do. It's like, oh, we should really look more into that. Oh, it's like, we should need to look more into that. There's just so much stuff that's coming out of this. It's going to be very rich, and there are more sequels to this than Star Wars movies will come out of the first one. Expanding practice facilitation. I think very interested in that and what that has to offer. And sort of the other analog that I've seen to that is the health IT support. In the Southwest, they have this great name for cheetahs, which I just love that name. I just imagine this animal running down the savannah and helping people move electrons around more effectively. And so we'd love to think more about that. And then, of course, shared decision-making is something we've dabbled in but really need to do more on. These are a few of the things that I've heard from AHRQ and from the federal side. But then over the last couple days, I've tried to listen in on conversations, discussions that you've had, conversations I've had with people here at the meeting that preceded this. These are some things I've heard from you. These are things that you have talked about. To reflect back, things like big data, and I have a little caveat around big data, because although I love big data and we couldn't do projects like Evidence Now without big data, I'm still a little bit of a big data skeptic. I worry a little bit about the wisdom lost in the knowledge, and the knowledge lost in the information. That big data sometimes masks the personal data, and I decided not to call it little data because that would mean that you have little data. But I thought small data, okay, that's a better way. That narrative part of data. And then where did I hear practice without walls? Was that Michelle Greiner? Did you use that one? It came up on our Wednesday thing. There was about practices without walls came up, which I thought was fascinating. That you never, practice could be everywhere and nowhere. And then sort of we heard talk today about virtual consultations or e-consults. I heard about health equity research and where does that fit into AHRQ's future. Certainly training the next generation of primary care researchers. I was impressed with the certificate program, but I know it's not had been funded for next year, and what can we do to help support that? It's got me thinking. Patient engagement, community engagement. We've heard about cross-border learning, sustainability, things that come up all the time. Data infrastructure for research and QI, linking primary care with community resources, integrating primary care with behavioral health, social determinants of health. These are things that you talk about that are important to you. So with that, actually, I'm going to stop talking, and I want to hear from you. And Arlene is here, and Ted is here, and I am here. But I want to hear what you guys are thinking. Where is your future? Where is our future? They are closely linked. And I won't even make you get up and walk to a microphone if you want. I have one in my hand. Who wants to start? Now, I was going to pick on LJ because I know you have something to say, and I know you wouldn't mind if I pick on you.
So I've always enjoyed this meeting. It's small. The big NAPCRG meeting I get lost in, and we have maps and the program that tells you where to go, and I always feel bad I can't make it to a lot of the sessions, but this is a meeting that seems to me that we can get our hands around, but there's one thing that's missing from this meeting that we used to have, and that's practicing clinicians. Back in the days when we had it early on, we would have people that were from our practices participating in this meeting. And I'm not quite sure how to get back to that. I think it was really nice to have from Colorado some patients from your group, and I really would like to see more of that. So I think I'd like to see multi-stakeholders, at this meeting, and to see where we can move that forward, because it really is about a practice without walls. That's the orientation of our network and so I'm not sure what the right term is for practice-based research networks, but the word practice is a little bit confining, and we need to think about what it looks like now.
And what can we do to help you think about that? Don, yeah. And again, thinking about the future for AHRQ, whether it's AHRQ or whether it's NERSC or whatever we
So
call it.
one thing that I've been playing with in the last week or so, just at our place in Colorado, and pushing my chair on this a little bit, Frank, who's a good thinker about this stuff, is that the IOM's definition of primary care talks about primary care being practiced in the context of communities and families. And I think in the context isn't adequate for what we need right now. I think it needs to be practiced in partnership with families and our communities. And that I think could shift us significantly. And that's what I'm thinking about.
Yeah, great. No, thanks, Don. Appreciate that insight.
My name is Annette Totten, and I'm at Oregon Health and Science University.
Great to see you.
Oh, can you hear me?
Yeah.
Yeah, okay. So you asked about past and future,
Yeah.
and so part of my past is I was an AHRQ pre-doc fellow, and I actually had a AHRQ dissertation fellowship, and I met Dr. Eisenberg because he used to come around and meet all of the pre-doc fellows.
Yeah.
And he said something to us when he met. He said, I do this because if I fund you now, I can claim everything you do for the rest of your life.
I love it.
And that is true in a sense. Yeah. And, you know, I was at OHSU for 6 years, and I knew about OPRIN, and I wanted to get connected. And it was only when the fellowship announcement came around that I was able to figure out how to do that. And one of the struggles that I think some of us have, so this is applying the past to the future, is, and I know NIH is trying to address this with some sort of formula so that to break the sort of concentration of grants. You know, those of us who are sort of below the baby boomers, but in a lot of departments there's full professors and assistant professors and nobody in the middle. And I was trying to think about the things we need to move projects forward. And, you know, it isn't dissertation grants maybe anymore, but it's really hard to get pilot money, or not the exact model of PCORI pipeline to proposal stuff or pipeline to partnerships, but there's harder and harder to get mechanisms because we don't have internal money anymore in our departments. Like, I'm 100% externally funded. Actually, I'm not supposed to be, because you're not supposed to be more than 95. But we fight about that.
Ouch.
Yeah. So, you know, so where do you get the little bit to do the developmental work anymore? And so I don't know if there's something that AHRQ could do that would not cost a lot of money, but then they could claim everything we do for the rest of our lives.
Love the idea, yeah. You know, it came up at the fellows thing. So the R21 that people were thinking about, is that sort of the mechanism? As opposed to R03, which is, you know, small amount of money, short amount of time, doesn't quite get there perhaps.
The structures of the K awards can be difficult. Like you know, the traditional career path doesn't really work anymore. You know, pre-doc, post-doc, K award, R01s for the rest of your life. So some of the constraints on the K awards don't acknowledge sort of the different career paths and different disciplines that people come from.
So thank you for that. And I guess what I'm starting to hear too is sort of this: how do we sort of build this, you know, pipeline of researchers who are committed and have mechanisms all the way along the way through maturity? So, Jonathan, yeah.
Well, thank you for that world tour of it's just amazing to see it in perspective. And you're reminding me that I had an NCHSR dissertation grant, so please take credit for that grant, and Norman Weissman, who was the director of that program then, was really instrumental to, I think, a field of comparative effectiveness research, even though it wasn't called that then, it was technology assessment. So I want to make 2 points, and the future, and I hope AHRQ is alive and well and vibrant in the future and continues in its independent mission in partnership with the other DHHS agencies. And so I hope we all convey that to, if we can get our senators out of the rooms where they lock themselves into, so that we remind them of the importance of AHRQ. But the point that I wanted to make is, if we were talking in this room 5 years ago about patient-centered outcomes research, relatively few people would know what that meant or would really resonate to what it meant. But it took $1 billion of funding getting pumped out the door in a relatively short period of time to get a lot of people to speak that language, and to have that kind of spread outside of PCORI, to have people talk about its patient-centered as well as clinical outcomes that should be evaluated. So clearly putting money behind things. So I want to acknowledge that, that our P30 grant as part of the practice-based research, Center for Practice-Based Research and Learning, has been transformational for us, and I think for our partners here, because it put money behind the idea of us working together and having inter-PBRN, inter-network collaborations, networks of networks. So I think that was really important at 2 levels. One is from a business development standpoint. I think all of the P30s can really claim success, and for our CDN and our N squared, it's really changed our approach to the way we did business. And in fact, when we wrote the clinical data research networks applications in New York and Chicago, we took the same template of a network of networks and how it worked in the P30. So that's something to claim credit for. But I think the second point, which is the more important one, is that working with health systems that are going to be the delivery agents is going to be really critical to the dissemination and implementation of research. The degree to which you can realign your priorities and funding to support, encourage, require the networks of networks to better align their activities with the large health systems agencies, delivery organizations, will really be that learning healthcare system that will implement these principles. So many years, muchos años, and thank you for this beautiful tour.
Mickey Eater. LJ made an interesting comment because I was introduced to practice-based research by both a clinician and a researcher. And I think we have to ask ourselves if we've fallen, not just what can AHRQ do, but what can the people in this room do in some ways, and whether we haven't become a little insular. And are we sharing what we're learning locally? And are we doing a good job of building a community that not only participates in projects that we initiate, but is informed about them, has the opportunity to directly learn from them and benefit from them. And I think that we all have to start thinking about sustainability and so on, but also dissemination. This meeting, we started going in that direction. There were people talking about implementation, but I don't think local dissemination is on the radar yet. And as we really start thinking, we're interested in publishing, that's great, but most of the clinicians I work with don't read the journals we publish in. So I think we have to commit to doing more work, and it would be nice to have some support in order to be able to really get out into the public domain and clinicians and potentially patients, helping them understand some of the issues that we're investigating in a more dialogic way and engaging the public.
So what can we learn from the past? So I'm going to tell you about my past. Both my parents are Holocaust survivors. My dad is a sole survivor. There's no one left in his family. He was 8 years old. Okay? What can we learn from the past? If good people do nothing, then bad things happen. You know? And it was a gradual process. I don't know if anybody's read Margaret Atwood's The Handmaid's Tale. It showed how it happened and how they did it. And it was taking gradual control, you know, and suddenly women couldn't work and they closed the bank accounts because they had the data to do that. What can we learn from the past? Say no. Say no. It doesn't have to be that way. Things go in cycle. You don't have to accept that. You'll have to work with people in power, and the same in Canada. You know, it is a democracy in Canada. It is a democracy in the States. You don't have to say that, yeah, this is the way it is. You actually have the power, but you know, you're gonna have to, we're gonna have to work pretty hard. One of the things that probably is really good at the present time is let's work, you know, cross borders. We have no wall. There's no wall across the border, and I'm gonna fly back. No wall. I think, you know, I think the more we collaborate, the more we work together, the more we can show that, hey, people are people are people are people. You know, it's actually the same. The better the case will be. But, you know, these problems are people problems, they're political problems. You don't have to accept this. It doesn't happen, doesn't have to happen again, never again. You know, the generation before mine said never again. It doesn't have to be so. Make it not happen.
All right, thanks. I'm Melinda Davis, also from Oregon, so sorry for dominating. I actually started in the PBRN community back in 2007 as a practice facilitator and have had the opportunity to really benefit from many of the initiatives that AHRQ has funded. So for the original Master Contract Award, through the P30s, and now through the Evidence Now. Although I'm not working on it, I'm now a faculty member actually with the AHRQ Patient-Centered Outcomes Research K-12. But I've really had the opportunity to benefit from some of the infrastructure support that you've provided. And one of the things that I think was really wonderful with the Evidence Now initiative is that many PBRNs were able to scale up quite systematically the kind of infrastructure they had for practice facilitation and for building continuous relationships with their practice members. And so as I'm thinking about what AHRQ can do moving forward and thinking about many of the leaders in the PBRN community who might be thinking about retirement or what's next for their future, I think in order to entice kind of the junior faculty members who are at this assistant professor level and hoping to stay in the profession, but to continue to support these infrastructure opportunities that really allow for critical relationship development and relationship development before there's a research award and you're pounding on somebody's door to say, I need a letter, does this match? And that's not just for primary care, but for community partners. And as the health system increases in complexity, as primary care clinics affiliate with larger health systems, I actually think the effort that needs to be put into those relationships and to develop those trusting partnerships is perhaps even more complex than it was. So I would commend you for what you've done and encourage you to keep exploring opportunities to move that forward.
Thank you, Melinda. Appreciate those insights. Very helpful and great to hear your perspective on that.
Hello. So I'm a newbie, and I struggle because by the definition of research, you're trying to isolate out all the variables, and yet the whole intent is to look at the big picture. We're looking at potential dramatic cuts in Medicaid, and one of the things where I see a tremendous opportunity is the nexus between the surviving NICU babies, the people living with disabilities throughout their lifetime, and for the first time in history, people with disabilities are living a typical life expectancy. We see aging parents having cared for their adult children with disabilities, and then they both hit the system at the same time in long-term care. And so the primary care physician, you've got the specialty clinics and all the specialties, but nobody's tying all the things together. And I just see a real opportunity, specifically in long-term care components, and patient-centered medical home is the foundation, but looking at that with more intentional purpose.
The care coordination part in particular. Thank you, Kelly. Appreciate that. Well, let me pause for a moment then, and I know we have a couple folks who colleagues at AHRQ who are as committed to primary care as I am, if not more in some ways. So Arlene, did you have some things you wanted to say? Here, I think.
This has been great, and it's been great hearing from everybody, but I just want to say we need your help, because what people care about these days is return on investment and impact. So we fund you. You do all kinds of great things. We don't always collect it or be able to, brag about it. So we really need to hear from you about all your success stories so that we could highlight them. We're doing profiles of different bodies of work at AHRQ. So if you have ideas for us about how we could really demonstrate the value of the PBRNs, the value of primary care research, really concrete impact, not like a publication, please, we really need your help, because you can help us kind of, explain to people why this is such important work.
Thank you, Arlene. And Ted, I want to give you a moment also, if you don't mind, just to sort of, you've been deep into this now.
Yeah, thank you. Excuse me. The amazing thing for me is having been at the first several AHRQ-funded PBRN meetings a gazillion years ago. I remember delivering a few of you. And to see that the movement is still here, it's going on, where you're talking and thinking about things that we didn't think about, because it's a continual evolution, and it's very, very exciting. The only real thing to add from your great thoughts and what Arlene just said, which is very important, is that Bob and I were talking earlier about how many of you have come up to us and said, how you doing? Is there anything we can do to help? We are touched. It is wonderful, but that's not the right. It's more what Arlene was saying. We're here to help you. The last half hour of discussion has been fantastic, but we're all not sitting around doing nothing, but we're all sitting around in our offices working, waiting to hear from you of new ideas, new problems, how can we help, etc. So we're here we all believe in primary care. Absolutely, we all believe in PBRNs, and we want to work with you to make things move forward.
Hi everyone, I'm Alex Fix from PROS at the American Academy of Pediatrics and PERC at Children's Hospital of Philadelphia. A few quick comments first. Have to underscore the infrastructure piece. I wonder if, just sort of drawing on the comment that Ted just made, if there would be any value to having some of the leaders of the current P30s or some other folks in this room get together to brainstorm what would be a compelling next generation of infrastructure funding for PBRNs, so that instead of, just thinking about, what might come to us, we can try to help spell that out.
Yep.
So that was one idea.
R13,
and then
I see R13 in the future. Yes. Sorry.
And related to that, as a pediatrician, I just wanted to sort of, as we talk about the past and future, just recall the sort of AHRQ priority population sort of theme and the role of children, which some large AHRQ initiatives sort of fit us well, and others just don't. And so just wanted to
Fair point.
put in a little hand for that one.
Thank you, and I'll take the knife. No, that's great. Thank you. Good feedback. Did you have something you want to mention? No. Okay, great. Other folks, other questions? Don.
Yeah, so one thing that I took note that you avoided, Bob, so I am going to bring it up, is the potential movement of AHRQ into NIH.
Yeah.
And I can see potential pros, I can see potential cons. On the con side, one worry is that within the larger NIH budget, AHRQs, both, you did such a great job of laying out the history and this sort of institutional memory within AHRQ of the importance of this work. And I worry that could get sort of lost in the big NIH sort of thing. So I know you guys are thinking about this a lot, and I don't know what you can say, but be curious.
So I'll say some stuff just because, Arlene can correct me later and I can get, but actually, partly we just don't know. I think it's still being folded out. I know that we are referred to as the National Institute for Research on Safety and Quality in the President's 2018 budget. Andy Beinman wrote, I thought, a really nice article that talked about both the possible pros and cons for that kind of thing. And where is Barbara? Barbara, are you here? We were talking about this as well. You have some experience in legislative and policy circles, and that, perhaps it could be a good thing if AHRQ brings its AHRQness and its focus on primary care to NIH. And what if we could, seed that interest to other institutes that don't typically think about primary care? There may be some advantages there. There's also disadvantages, which you potentially highlighted, and I can imagine, as it's right now, it's an institute is what it could potentially be. And I don't know if there's anything more that we can say about the uncertainties of it. I think it'll take time for these things to roll out, but I don't think at this point, I can't imagine that it will change our commitment to primary care in that way.
I think the devil's in the details.
Yeah.
But what I just want to say again, I think it's important for the community to voice what they think it needs to be. And to me, what's unique and why I love being at AHRQ is we have a synergy. It's like our whole is more than the sum of its parts. Like I direct the evidence and practice improvement. We have patient safety. We have delivery and organizations and cost and financing. And there's a way we work together on those different real 4 major domains of the health system that I think it's important to keep together. But I think this is a time for the community to say, what do you want a federal agency that funds both primary care research and health services research to look like? And get the ideas and voices out there and express the pros and cons. I think this is a time to speak up.
Oh, great, thank you. Does that help, Don? Yeah. And you notice I did include it on the slide. It was on the quiz. Okay, well, I think with that, what I'm going to do is I'm going to move to the last couple things so you guys can get out of here. And I just want to, this was so I didn't go too far on my slides, to say, are you now as confident as I am that the state of primary care research at AHRQ is strong, based on our past, based on what we've done in the present, and where we can possibly go in the future. And I know there's tremendous amount of uncertainty that continues about that, but as Arlene said, I think you guys are uniquely positioned to help keep this strong. And I second Arlene's plea on that. And then I also wanted to just sort of offer one last quote from my historical perspective and some of those documents to really to talk about how our futures are linked. And I'll read this one again from Harvey Estes. The fate of the new agency, and at the time he was talking about AHRQ, and primary care are closely linked together. If primary care research can assist AHRQ or AHRQ or NERSC or whatever we're called in effectively addressing the problems of unmet healthcare needs in an era of restrained funding, its hand will be strengthened and improved healthcare in the future will be virtually assured. I still think those words are remarkably valuable today and speak to how closely linked our mission is with the work that you guys and your colleagues do. And I think that's important for us to keep in mind as we move forward. One of the last things I want to say is that we are not nameless, faceless bureaucrats at AHRQ. We are people who have lives and who are committed to this. And I did not wait 25 years to come to AHRQ to have this go away. Here is the team that inspires me every day. David Myers, who's our spiritual leader and sort of the main reason I came to AHRQ, for the opportunity to work with David. Arlene, who you've heard from, been a great leader for our Center for Evidence and Practice Improvement. Tess Miller is our chief storyteller and makes things happen. Jan Ginevro is our social worker, counselor, clinical psychologist, and the queen of context at primary care. Ted, who you've met and is leading our new center. Then there's also Rick Ricciardi, who's a nurse practitioner, PhD type, committed to team-based care and primary care, who brings a DoD history perspective to the team. And then Chun Lu Zan, who I have to mention, because every team has to have an economist to keep us grounded, and that's the role that Chun Lu plays, and there are many others. A question came up, Don and I were talking about what should we talk about today? What would you like to hear? What can I tell you? And one of the things that struck with me is, where do we send our ideas? Here you go. I've got cards, happy to hand them out. We are here to serve you, and we want to make sure that what we do aligns with what you do. And we need your ideas and your stories to help keep us strong. So with that, I just want to make sure I thank you for what you've done in the past, how you've helped us build a strong present, and all the work and support you're going to provide in the future. So thank you for the opportunity to talk with you guys today.